I'm Dane. My name is Thomas Feldthus. I am VVD and CFO of Saniona, which I founded about 4 years ago together with the CEO. We are, as mentioned, listed today at Aktietorget, and we are aiming at going to small cap Nasdaq list this year. There are 3 things I would like you to remember when you think about Saniona. And that is that this is a company with top-class science, with a number of very interesting programs, and lots of collaborations. And these things make us quite independent because we are able to generate revenues and value already today. This year so far we have entered into deals which provide us revenues of 20 to 25 million crowns just this year, and there will be further revenues from these deals also next year. So what do we got? We got a world-class team within our field of research, ion channels. This leads to a number of different indications: CNS, metabolic diseases, and autoimmune diseases and pain. We have right now 9 active programs, of which 5 are financed through partnerships. In addition to this, we have a platform and a number of early discovery programs and also a couple of clinical assets which we are ready to make up for partnering. So I used this slide in the autumn in order to illustrate the development of the company when we raised capital in November. And what we basically was that we listed the company as a drug discovery company in April 2014, and then we were raising capital to take one of our programs into phase 2 clinical trials. And also we said that we would list the company at Nasdaq this year. This product is for type 2 diabetes, and I can say now that we said that we would do it in the first half of this year, and we are on track. We are right where we want to be with this program at this point in time. So I'm confident that we're going to start this trial. Also, 2359, we said that we had actually an IND approved in the US to start, but we were waiting for funding in order to take this forward. And our partner, University of Pennsylvania, has now informed in December that we will take this program into phase 2 clinical trials during the first half of this year, after they have received a grant from the US government, from a Dana Foundation. And this trial is also going to happen here in the first half. So here we are on track. Phase 1, program 363, there we were working on, you could say, preclinical development finding, and we are still working on this in order to see whether we want to take this program forward into phase 1. And on top of those 3 programs, I can now say that after we made a deal with Medics here in February, it's likely that we will start a phase 3 study for tisofensin in 2016. This is what they have informed us that they intend to do. When we are looking at the partnering side, we were also quite bullish in November. We said that we wanted to make a partnering on one of our clinical assets. We said that we would like to make collaborations and spin-outs based on other programs from our platform. And then we said that we expect to make a new collaboration for at least one of the programs which was returned from Pfizer and Janssen. We have delivered right now at the first line with the Medics deal in February. We made a delivery on the second line with the Upsa-Smith deal in January, and with the Michael J. Fox Foundation's grant in February. What's still outstanding is on this line, but I say that we are very optimistic about the possibility to make a collaboration on this, one of these assets this year. So this is what we, so to say, promised, and this is where we are 3 months later. We are based on partnering, and we do this in 3 different ways. So we are making research collaboration with partners where we will they will finance the program, and we will receive milestones and royalties on product sales. We've named a couple of those. Then also we are taking selected programs and developing them internally in order to build further value into these programs before we out-license them to third parties. And finally, we make spin-outs, such as the one we did with Ataxion, Biogenetic, and Ataxion Atlas Ventures, called Ataxion. I'll come back to this one. It could be through venture capital here, but it could also be through a separate listing at Aktietorget, for instance, and Lex Lucia rules here in Sweden. So this is an overview of our pipeline. We have, as said, 9 programs. 3 of those has come to the pipeline this year. At the top you have the program for obesity, where Medix plans to start phase 3 this year. Then you have our program for Tisomet for type 2 diabetes, where we expect to start phase 2 clinical trials this spring. And then we have the program together with University of Pennsylvania, where they're based on government grants. We'll take this program for cocaine addiction also in phase 2 this spring. And then we have 3 programs which we are financing right now internally for neuropathic pain, inflammatory bowel diseases, and schizophrenia. And then 3 discovery programs together with partners, Biogenetic, Atlas Ventures, Smith, and then actually internal product, which is funded by the Michael J. Fox Foundation. And again, we have additional programs which we are putting minor resources into right now also, in order to make these types of deals as we just did with Smith and Michael J. Fox Foundation. So quite a lot of technology and assets. A little bit about the clinical assets. So Tisomet, which we plan to start for phase 2 clinical trials here in spring. This is going to be a patient study with 16 patients. 30 will receive placebo and 30 will receive Tisomet. It's going to be a 3 months treatment. And the primary endpoint in this trial would be that we will demonstrate that there's a combination of metoprolol and tisofensin. And the primary endpoint here is actually to show that we can blunt the increase in heart rate we saw with tisofensin as a monotherapy. And second endpoints will be effects on glycemic parameters, such as HbA1c seen here, sustained weight loss in these patient groups, and also a reduction in liver fat. So we scan the patient, see whether we can reduce the liver fat also in these patients. We have actually, through a data mining of an old obesity study, shown that we are able to, with this compound tisofensin alone, to have a significant weight loss in type 2 diabetes patients. And through this, to achieve a normalization of the glucose level in the bloodstream of these pre-diabetic patients. We have also shown in a phase 1 study that by combining tisofensin with metoprolol, we can reduce the heart rate to normal in volunteers. So we have the individual components in different patient group or volunteers. And now we put it into real diabetes patients in order to see, also we hope for much more dramatic reduction during the period. And therefore we are, since we have the different components, fairly optimistic that we will have successful outcome of this trial, which is going to be very important for our partnering activities on this project. Then 2359 for cocaine addiction. This product is probably can be the first product to enter the market for cocaine addiction. There do not exist anything today. So if people are getting addicted, they are in serious problems. Clinical and preclinical data indicate that this compound will result in an experience from the addicted person to a reduction in withdrawal symptoms when they stop taking cocaine, and also a reduction in drug craving, the need for more cocaine. And again, finally, a reduction in the euphoria associated with taking cocaine if they still decide to take it. So these data here show something from a phase 1 trial, which was tested in 24 persons who are using cocaine on a weekend basis for fun. And these patients, or individuals, were given 1 dose of 2359 followed by a dose of cocaine of 40 milligrams. Or they were given cocaine alone. And then they were asked, what do you think about the cocaine you got? And they said, well, how much will you pay for it? And what you see here is that the light blue is one who got the single dose of our compound followed by cocaine. They would pay much less for the cocaine they were asked for. So if they paid $40 for this, they will only pay $20 or $15 for the cocaine after they have given 2359. So they did not have the same pleasure. Also, they did not like it to use it. They did not feel stimulated. Importantly, they had not the same desire to take cocaine as if they were not getting 2359. So this gives an indicate that they have not the same pleasure of taking cocaine. Also, it was measured some, you could say, clinical parameters in this trial. And it is so when you take cocaine, there is a dramatic increase in heart rate. And there is also a smaller increase in blood pressure. And we were then looking into, could we also reduce the increase in heart rate? And the top one you see here, what happens to a person taking cocaine for these 12 people who just did not get 2359. They were getting typically a heart rate from, which is about between 60 and 80, was increasing to more than 120. And it is this one of these cardiovascular issues which is the cause of death when people are taking overdoses. When we saw here with our compound was that it actually was reduced, the heart rate was reduced. So we did not see the same increase when they took cocaine afterwards. And this is important because many products which have been tested in this for cocaine addiction, they had an additive effect. So there was additive, they were actually heart rate increased if you were taking both. And this, therefore, they were not developed because you will put, you could say, the addicted individuals at risk of dying if they were dropping out of the trial. Here we see the opposite, we see a reduction. And actually this parameter can save a lot of lives. So this will be another argument for Register. So what's going to happen? We will take the patient, there will be 60 to 80 cocaine addicts participating in the trials, half of them placebo and half of them with our compound. And then 8-week studies, and the primary endpoint will be abstinence for cocaine during the last 2 weeks of the trial. Also, we will have measurements for reduction in drug cravings, reduction in withdrawal symptoms, reduction in alcohol consumption, and reduction in smoking. It is so that cocaine users are often also alcoholics and heavy smokers. And 2359 could actually also be used perhaps for these types of addicts. And then finally also an improvement in cognitive endpoints in these patients. This is this trial. So a little bit about the Michael J. Fox Foundation. So Michael J. Fox is an actor who got Parkinson's disease very early in life. And he is then spending now much of his time to raise funds and sponsor research in this field. He's sampled an advisory board in the US, and it's very esteemed advisory board. It's very difficult to get these grants. And therefore, we're very proud of having this grant because it clearly shows that we are in forefront on this in the industry in relation to these matters. So what is it? Parkinson's disease develops when dopamine producing neurons in the brain, in a small area in the brain actually, called substantia nigra. This is this red dot here. When they degenerate, then these neurons, they help make second messages to the muscles and to your movements. And if they degenerate and die, then the patients will start losing control of their muscle and their movements. And that's basically what happens in Parkinson's diseases. It is known that smokers have less risk of developing Parkinson's disease. There's a lot of these types of studies around, big studies, even where you have twins where one is smoking and non-smoking and so forth. And it appears that nicotine will protect those neurons up here in substantia nigra. And also they will stimulate them to produce more nicotine and more dopamine. And it is believed that nicotine alpha-6 receptors, they are called, they target for nicotine in these neurons. And these receptors are almost exclusively expressed in these cells in substantia nigra. So they are an ideal target for Parkinson's diseases. And Saniona is probably the first company to report that we have identified compounds which are specific for these receptors, and that we can modulate these receptors in vitro. And this is why we get a grant from this. And we believe that such compounds will be able to protect the dopamine neurons for further generation, and thereby perhaps be a disease-modifying concept in Parkinson's diseases. And also, we think that they can reduce the symptoms of Parkinson's diseases. So this is what this program is about, where we got a grant here in February. We made 2 deals also here, one in January and one in February. The first one is fairly standard. It's together with Jupiter Smith. We will receive a small upfront. They will finance everything. All risk is taken by them. We will receive up to $30 million in milestone payments and then royalties on product sales. So that's pretty standard. When we come to Medix, that's not so standard. It's quite an interesting deal. So Medix, this one we did in February. They will develop tesofensine and tesomet for obesity in Mexico and Argentina. They will start with phase 3 clinical trials for tesofensine. They plan to do this year. And later on, we expect them to start phase 2 and phase 3 trials for tesomet for obesity for these markets. They are only getting rights to Mexico and Argentina in order to do so. We will have milestone payments on this, and also we will have double-digit royalties on product sales for their sales in Mexico and Argentina. More importantly, perhaps, is that we also have the right to the data they develop for the rest of the world. So this is a way for a small company like us to actually have late-stage clinical development. So very interesting deal. Then we have some existing collaboration. We have one, a spin-out called Attraction, which is financed by Biogen and Atlas Ventures. They put $70 million into it. We own 14%. We are doing the research on a fee-for-service agreement. And then Biogen has a right to purchase this company after phase 1. And then we get 14% at what Biogen pays if they do so, plus royalties and product sales. So a little different structure than usual. And then finally, we have to deal with the University of Penn for cocaine addiction. And the important thing to say here is we retain all commercial rights. They are funding this on grant and also internal funding. They're interested in doing this. They are non-profit, and we will retain all commercial rights. I've tried to illustrate something here about financing and commercial rights. And on the top left corner, you have our internal development programs. Here we will have, of course, the commercial rights because we are financing it. So this is the AN363, AN346, and 470 for schizophrenia here. Then we are developing them internally in order to partner at a later stage. And therefore, these represent, you could say, future revenue generation, future upfront and milestone and royalties. Then we have 2 research collaborations down in this corner. This is a third-party financing, but they also have the commercial rights. The upside for investors here is that we will have milestones and we will have royalties on product sales. So we will protect those and put them down in this box, basically, and make money in this way. That's basically how biotech is working. Now, interesting is there is also this box here is called a free ride, I can call it. And here actually we have 2 products. We have the Nicotine Alpha 6 program, where we are funded now by Michael J. Fox Foundation, but we retain all the commercial rights. So this is even better than this, basically, for investors. And then we have this clinical program where we are running a phase 2 trials together with the University of Pennsylvania, also based on government grants. And where do I then put the Medix deal? I put it here. It's kind of cross-border. Because they will develop tesomet and tesofensine for obesity. And then they will get a small part of the market, Mexico and Argentina. But we will have the rest of the world, and we can use their data. So this is an interesting deal. Also, then we will do also investment in tesomet ourselves for type 2 diabetes this year in Germany. And then they will also benefit of this. They can refer to these data because they have the right in Mexico and Argentina. But it's a small part of the market. We think this, and we will get very high royalties, double-digit royalties on sales in Argentina and Mexico. So we think that this is a tremendous and very interesting deal for us. So if you look for investors, this is, you could say, future revenue generation, future hope. This is where we're investing. This is, you could say, risk-free for investors. It's true upside. This is even more interesting because it's risk-free for investors, but we have all the commercial rights. And here, this is, in my view, extremely interesting because this is a way for a small company like us to have late-stage clinical development and still retain significant assets. Right, I'll split this in the interest of time. Just saying here that we have the share price, we raised at 5 crowns per share in April 14. It's trading about 16 crowns. This gives the market cap of 335 million crowns. The daily average volume in the last 12 months was 2 million crowns. We are followed by Biostock, Redeye, and Small Cap. They have a risk-adjusted share price of from 38 to 103 crowns, so well above our current trading price. If you look a little about news flow and inflection points, then we have made 3 deals already in January and February this year. We see a number of important inflection points coming up. Initiation of phase 2A for Tesomet here in spring in type 2 diabetes. Initiation of phase 2 for 2359 for cocaine addiction, again here in spring. Potential start of phase 3 for Tesofenz in obesity this year. Also progress and ongoing programs, including AM36 for neuropathic pain. And finally, new combination. We see good opportunities to further deals this year, and update on our plans for NASDAQ listing also here in 2016. So a very eventful period coming up here. Summing up, we are moving programs into the clinics right now. We could have 3, potentially 4 programs coming into the clinics this year. We have a world-class team within our field research. We have already shown that we can make 3 deals on this partnerships this year based on this. We have seen many future inflection points coming up in the coming period, and we are moving towards NASDAQ small cap here in 2016. Thank you for your attention. Okay.
Och nu ser ni att vi är en Mats mindre här. Nu blir det Marcus här som kommer ha lite frågor. Ja, vi sätter oss ner.
Okay. Right. Can everyone hear me? Yes, I think so. As you told us here, your business is mainly based upon partners, and you have been successfully aggressive about gaining such partners recently. There has been setbacks as well. But how about the risk for infringements and conflicts with partners around the globe when you
the risks
the risks for infringements and things like that, and problems in partnerships and so on.
Patent infringement, or
for instance, or for problems in relationships with those companies and so on, legals and things. No.
When you're going into partnerships with the large companies, they are very careful moving into partnerships, and they only want to make partnerships with companies which has something they don't have internally. Therefore, you can say it's quite amazing that a company like ours can go into partnership with Pfizer and Janssen, as we had last year, because basically they are so big. So why? What do we have? But we are very strong in what we are doing, and they are also very careful when they are moving into to this territory, because they don't. How can they make due diligence without learning something they didn't want to know? Yeah. So I think they have even bigger problems than we have. Yeah. Because they are afraid of learning something they already knew, and therefore will have some obligations. Yeah. So that's a very slow collaboration. That's why part of it, why it takes so much time to make these partnerships. So for instance, the deal we did with Upsa Smith in January here, we met with them first time, I think, in November 14. And had a very good meeting with them at JP Morgan conference in January 15. And then it took a year to make the deal.
You create a mutual understanding about
understand what it is, slowly moving into what is it you have, and is it okay? Yeah. And then they make that due diligence. So that's it takes time. Yeah. So I think it's a both side thing. When it talks about infringement, then I think infringement of a patent, that's a problem for everybody, of course. It's more know-how you are having, you're sharing, which is the issue.
Of course. Jag undrar om vi har några frågor från publiken här och jag kan försöka översätta dem till engelska.
Yes.
Längst upp.
Ja.
Ja. Kommer en mikrofon.
Ja, det gör det.
Is it on? Hi. I was very impressed by your tesofezin, your anti-obesity drug, and getting it all the way through to phase 3. My question is, do you have any competitors for anti-obesity on the market? Because to my understanding, there are very few anti-obesity drugs on the market.
Yeah. So
It must be a very novel mechanism.
So I'm not sure I understood the question exactly.
So you must have a very novel mechanism of action for tesofezin. You didn't talk about mechanisms of action, so I'm just wondering, what is the new? Is it a novel mechanism of action for this tesofezin?
For tesofezin, yes. So tesofezin has been tested in I didn't show this data. I can show you a little bit. It was a long question. But tesofezin is a monoamine reuptake inhibitor. And I see whether I have some data on this. Triple monoamine reuptake, I can see the principle here, maybe. Yeah, no, there's no, I don't know. So it's a triple monoamine reuptake inhibitor. And it has been in phase 2 clinical trials by neurosurgeons in the past, in a trial called TIPO2 and TRIPO4 trials, where it's been tested in quite a lot of patients. And in 4 different doses. And we saw a dramatic weight loss with this compound. So basically how it works is it's working on the dopamine system, the serotonin system, and noradrenaline system. And when you're talking about dopamine, then it regulates appetites. So you are not feeling that hungry. And second, when you're looking at the serotonin system, actually then you're increasing the burn in the body. So it's a dual effect, you could say, in patients, or in the individuals. And we saw this compound was originally tested in complete different indications, and then you start seeing that people in these indications were actually losing weight. And then neurosurgeons tested for weight loss. And they got, I think, 11-12% placebo-controlled weight loss in these patients after 6 months. And if you compare it with the products on the market, like Victoza, which is one of the best ones from Novo Nordisk, then they have a weight loss of about 7% after 1 year. This 6-month study was extended to about 1 year in an open-label study. And the patient participating in open-label study, they were offered to go back into the trial. They actually had a weight loss up to 13-14% placebo control, so more than 15 without placebo. And now we're then moving into a territory where it is competitive to operations, where gastric banding, for instance. And this makes it highly interesting, because it has been shown that if you receive that sort of weight loss in type 2 diabetes, now I'm not talking obesity, but I'm talking type 2 diabetes, but you have that sort of weight loss in type 2 diabetes patients, then they will start to lose liver fat, a lot of it. And then the liver starts working again. And then that glucose level in the blood will start be normalized. So there has been a number of studies, some of the first one 10-15 years ago. One of the biggest studies actually performed here in Sweden, where you took patients into gastric banding, and other patients would just put a normal therapy, and then you see what happened. And patients going to gastric banding, that was where you're putting a clamp about the stomach, they were going out of diabetes long-term, also in long-term remissions. And this is what we are going for with this program. We want to look into see whether we can bring glucose level down in these patients by a reduction in liver fat in these patients, because that's really the cause of the disease.
So type 2 diabetes will be an enrollment criteria for the study, is it?
Sorry?
Is type 2 diabetes an enrollment criteria to join the study that you'll be initiating?
The study we initiate?
Now, I'm just wondering if you have that as a criteria that the patient must have type 2 diabetes to get into the study, or do you have a body mass index criteria that to be enrolled to join the study, to sign up for the study?
Yes. So you're asking about the protocol we are following?
Yeah, just the protocol.
So we have produced the tablets to be used in this study, and we are discussing the final protocol with the authorities. And what we are looking for is a 3-month study. This is what we can take right now. And if you say whether we get a signal, then if I go back to slides, then here, sorry, this one. So this one shows the result from pre-diabetic patients. So we had this type 1 study where we were looking into obese patients. This is an obese patient trial. Diabetic patients were not allowed to participate. When we went through data mining in this trial, it turned out that 25% of the patients participating in the trial could be defined as pre-diabetic because they had HbA1c level of between 5.7 and 6.4. Okay. And what we saw here, as you can see, is that the patient receiving tesofensin 0.5 milligram, which is the dose we are going for, actually had a reduction in HbA1c down to, after 24 weeks, down to below the line. Actually, already after 4 weeks, it was down to the normal line. And it was, you can see, statistically significant despite the low number of patients. This is not impressive reduction, but it shouldn't be, because they were close to normal. When we are going then into diabetes patients, often we want to see a higher reduction. And then we would like to take in patients with as high as possible, of course. But this is up to discussion with the authorities how far we can go. The higher patient we can take in, the easier it is to show a reduction. But we will still have this up to discussion. So I cannot tell you right now what the protocol will be.
Are you hoping for sustained effects as well, that the effect will be sustained? Or
sustained?
Will they have to continue to take the medication, or will their weight loss be sustained?
Yeah, so in this trial, we are not going for sustained. It's not a phase 3 study. We just want to see the signal we can control glucose level. In phase 3, we will go for a long-term study. It will be a long-term, 6-12-month study, and then we will hope that we get complete normalization and get down to that level. Whether then when they then stop the trial, then you need to go back to, you can say, the concept of it and say, is this something which we believe in?
I beg your pardon, but I think
it's a long question, yeah. But yes, I think this is what we are hoping for, and it's clear that if the type 2 diabetes patient, as soon as they get out of the trial, start to put on a lot of weight again, then the fat will come back to the liver, and then the liver will get out of shape, and they won't be able to take up glucose as good as possible. And in that case, then we are back to normal situation, then we'll get back to type 2 diabetes. But here is something what we are offering the potential, we hope, to get out of the disease, to escape type 2 diabetes.
Well, good luck with anti-obesity, because I think you'll have market exclusivity if you get through the phase 3 and onto market. I mean, that's great for patients and...
Market exclusivity, what do you mean?
Well, I mean, there aren't any other treatments for obesity to date on the market.
Yes, that's true, but I mean, this is the kind of thing with if you take Victoza, which is probably one of the best on the market right now, which is giving 7%, it doesn't do the trick. People are not getting out of type 2 diabetes when they have a weight loss of 7%. So you will have fat loss in other parts of the body. You don't have enough fat loss in the liver. And there's a quite nice, interesting article about this recently by Roy Taylor, who is going through what happened to the gastric banding patients in Sweden here, what happened to the original patient, and also if you put people on a very strict diet, 300 calorie diet a day, there you also see the same things going on. And basically what he concludes is that 7% is not enough. You need above 15% plus in weight loss to get to that point. And then you don't have any competitors right now on the market. Because they don't
I think
exist,
we're
they're
out
not
of
that
time.
effective.
All right, thanks.
Okay?
Yeah.
Okay? All right?
Thank you.
Thank you. So, okay. Yeah.